Now, in the final section of our lecture, we will talk about the cesarean section. In this section, we will talk about the classification of cesarean section. What are the indications of use of cesarean section and procedure, complications, and clinical risk management. Caesarean section is a surgical procedure in which incisions are made through a woman's abdomen, laparotomy, and uterus hysterotomy to deliver baby. So it's a surgical procedure in which one cut is given in the abdomen and then other in the uterus of the pregnant woman to deliver the baby. And nowadays more and more deliveries are done by the C-sections. Maybe the obstetricians nowadays, they don't want to go for all the complications sometimes which are associated with vaginal delivery, so they do more and more elective planned C-sections instead of a normal vaginal delivery. So when the abdomen is open, it's known as laparotomy, and then the opening of the uterus is hysterotomy. Steps in reducing mortalities associated with C-section. Adherence to principle of asepsis, because it's an invasive procedure. Very careful measurements should be performed to reduce the chances of getting infection or sepsis. So strong adherence to asepsis is important. Introduction of uterine suturing. Extraperitoneal C-section and moving to low transverse incision, and anesthetic advances, blood transfusions, antibiotic treatments. All these are the different steps which play an important role in reducing the mortalities associated with C-sections for delivering the babies. Classification types, we have elective C-section and emergency C-section. Elective C-sections, usually they are planned C-sections weeks or days before time. Usually the obstetrician, they decide that they will do C-sections. Emergency C-sections is usually irrespective of whether the woman was in labor or not. Degree of urgency varies depending upon classification. So sometimes the situation arises when emergency C-section has to be performed and it's not an elective planned type of C-section. These are the categories classification. In category 1, immediate threat to life of women or fetus. 2, no immediate threat, requires early delivery, and then category 4, at a time to suit women and maternity service. So all these are the classifications of emergency C-sections. If there is immediate intervention required, no immediate threat to life of women or fetus, requires early delivery, and time suitable. So all these are the classification when we should perform the C-sections. Indications. 4 indications account for more than 70% of C-sections. These indications are, if there is previous C-section, usually they go for section again. If there is breech presentation, if there is failure to progress in the labor, if there is suspected fetal compromise. All these 4 are the indications for the C-sections, very common indications. Mostly which C-sections are performed, one of these indications is present. Some other indications are multiple pregnancy, placental abnormalities like placenta previa or abruptio when normal deliveries cannot be performed, fetal disease, and maternal diseases in which C-sections are performed. Procedure is informed consent. Consent should be signed by the patient or by the guardian. Preparation and abdominal incision is given. Uterine incision. So 2 incisions are mainly given, one in the abdomen and then in the uterus. Informed consent is prior to surgery. Information is provided to in acute setting should come with urgency of procedure. So informed consent is the consent in which the patient is given all the information that this is what's going to happen and this can happen, and if they are ready to do that, then they sign the document. It's very important before any surgical procedure. Preparation can be spinal anesthesia, epidural, general anesthesia, bladder should be emptied, catheter insertion should be done, anesthetic block, cleaning abdomen, and prophylactic antibiotics. All these steps are in the preparation. Next, abdominal incision can be low transverse incision. This is low transverse incision, low vertical incision, and classical incision. Skin and subcutaneous tissues are incised. Transverse curvilinear incision 2 finger breadth above symphysis pubis. This is very commonly used nowadays because it's a low lying and it cannot affect the abdomen too much. Transverse suprapubic with no curve. Blunt dissection separate the subcutaneous tissue. So once the incision is made, then blunt dissection is performed to separate the tissue. So after the incision, blunt dissection separates the subcutaneous tissue. Then the separation is done using cephalad, mean the top portion or the front or the cephal is used for the top. Cephal is for the top. So separation is performed using the cephalad. And then the rectal separation is done after the cephalad, rectal separation, and then the peritoneum is incised. Peritoneum is the covering that covers all the abdominal organs. So after the incision is given in the peritoneum, then we enter the abdominal cavity. So peritoneum is incised and then entering into abdominal cavity, and then incision in the uterus, and then delivery is performed. So abdominal incision first in the abdomen, then separation of the subcutaneous tissue by the blunt dissection, and then incision in the peritoneum, and then we enter the abdominal cavity. These are some incisions that can be given. We have a midline vertical incision. This is the Maillard incision, Joel Cohen incision, Fenestrine. This is very, very commonly used incision. Now Fenestrine incision is performed. So all these are the different incisions that can be given in the abdomen. So vertical skin incision, maternal obesity, if the mother is obese, vertical big skin incision is given. Suspicion of any abdominal pathology, then we need the big area to go in, look for pathology and to remove the pathology. So the midline vertical incision. lower midline incision from lower abdomen to symphysis pubis or xiphi sternum, rectal incision if there is we need fat removal, incision of rectal sheath, easy access to abdomen via vertical incision. So all these are different abdominal incisions, and why we need different incisions for different reasons. Uterine incision. Lower uterine incision in 95% C-sections, lower uterine incisions is performed. Reflection of vesico-uterine serosa, blunt dissection, retraction of bladder flap, opening of lower uterine segment, extension of incision, membrane ruptures, application of fundal pressure. So all these are the steps. One, the uterus incision is given, fundal pressure is applied, and then at that point, even with the anesthesia, with the epidural, the patient feels very strong pressure which is given to remove the baby out. Membranes are ruptured. Administering oxytocic agent is important for the contraction of the uterus. Then the closure. In single or double layer, closure is performed. Continuous or interrupted sutures are used. Initial suture is given lateral to incision angle. Running stitch. Additional figure of 8 suture can be employed. Peritoneal and abdominal closure and skin closure. So as we open all the steps in which the abdomen is open, it is sutured or repaired in the same sequence. When we go in, we go from outside to inside. When closing, we come from inside to outside. So again, first the uterine wall is closed, then the peritoneum is closed, and then the abdominal wall is closed, depending on if we use the interrupted or continuous suture, or we can in single or double layer, that's different. But the steps, same steps when we go in, we should come out also. This is the steps for the closure of the uterine wall. This is the uterus. Then this is the abdominal wall, peritoneum layer, and then the abdomen is closed. Complications of C-sections, intraoperative during the procedure, we can have hemorrhage. Caesarean hysterectomy can also be performed and the uterus is removed. Placenta previa, organ damage can occur. So all these are the intraoperative complications of C-section. Post-operative infection can occur. Thromboembolism can also occur after the procedure. And psychological complications can also occur after the C-sections. Clinical risk management. Operational delivery is controversial, full of risk. Litigation occurs frequently. Appropriate training of operators, clinical incident forms, and risk management procedures. So it's very important that clinical risk management should be performed. If we do not pay attention to the risk and their management should not be performed, we can never improve our medical treatment. So it's important that all the risks should be discussed properly, litigations should be performed, and then appropriate training should be performed so we can reduce the risk of all these incidents and cases. That's all for our lecture, operative vaginal delivery and C-sections. Thank you for watching sqadia.com.